Welcome, everybody. Can you hear us okay in the back? Yeah, great. Thank you all for joining us. My name is Nasim Khavari. I'm the director of the Pediatric Celiac Center at Stanford. And this is Dr. Nielsen Fernandez-Becker. She's my adult colleague who directs the Adult Celiac Center at Stanford. We are very excited to talk to you about a topic that is passionate to both of our hearts. Thank you to the Gluten-Free Expo for allowing us to speak about celiac disease, as well as to the northern community of the Celiac Disease Foundation, and specifically Jennifer Iskall, who's been really supportive through all of this. So, the topic that we're going to talk about today is celiac disease, demystifying celiac from symptoms to diagnosis. There are three main topics that we want to cover during the next hour or so. The first, that not all gluten intolerance is celiac disease. The second, don't eliminate gluten until after you see your doctor. And third, that the treatment of celiac disease is lifelong gluten elimination. Myth: celiac disease is a rare disease. Fact: celiac disease prevalence in the United States is as high as 1%. However, many cases of celiac disease remain undiagnosed. This is a global presentation of celiac disease. The different colors present different percentages of celiac disease. And what you can see is that the darker the color, the more prevalent celiac disease is in these countries. So you'll notice that there's some areas, such as the United States and areas in Europe, where celiac prevalence is about 1%. And then there's some areas where it's even higher, 2 or 3%, such as certain portions of India, as well as some places sort of in the west of Africa. Over time in the United States, the incidence of celiac disease has been increasing. On the y-axis, you see incidence of celiac disease. On the x-axis, you see year and time. And each color represents a different age group. So what you can see is that the blue age group represents pediatric or children, the red ages 25 to 34, and the green greater than 35 years of age. And with time, the incidence of celiac disease has been increasing and increasing. Some of it is just because we're doing a better job diagnosing it and recognizing the variety of symptoms. And some of it is because we think there's probably something different in the environment that's also affecting this. So we're going to start with a case presentation and go from there.
So we'll start with a typical case. So in this case, we have a 41-year-old teacher with 3 children, and her symptoms are abdominal pain, some abdominal discomfort, diarrhea, and fatigue. These symptoms have been going on for many months, but they're getting worse. Eating seems to worsen the symptoms. And she goes to her primary care doctor and gets some basic lab and was found to be anemic. So what could this be? So the fact that there's abdominal discomfort involved, fatigue, makes us think that possibly celiac disease would be something that we would consider, especially with the fact that she has anemia. But we need to understand that there's many broad possibilities as to that could explain these symptoms. So, including this list, and there are other gluten disorders that we need to consider, but also other non-gluten related gastrointestinal disorders, such as irritable bowel syndrome, pancreatic insufficiency, to name a few. And we will have to navigate this. So, could this be celiac disease? What is celiac disease? We'll start there. Yes? Can't hear me? I'm sorry. Okay. So, did you get what I was saying here? Okay. So what I'm saying basically is that the symptoms that the patient was presenting with are very nonspecific, but there's some gastrointestinal symptoms, abdominal discomfort, getting gradually worse. There's some anemia involved. So we worry about celiac disease is definitely a possibility, but it's not a slam dunk. And there's a lot of other things that could explain that too, and that's what this slide shows. Okay? So let's talk about celiac disease first, because it's the disease that we understand the best. And basically, what this slide shows is a cartoon that illustrates the big picture. What we have is a situation when eating wheat, in this case represented by donuts, can then result in an immune reaction in the small intestine that ultimately results in destruction of the lining of the small intestine. And obviously the small intestine is extremely important. It's one of the few parts. You could probably live without a colon, you could live without a stomach, but you cannot live without a small intestine. This is where you absorb most nutrients. It's a very long tube, 22 feet long on average, and it has mechanisms to allow us to absorb nutrients. So here, what happens is that there's an assault on the lining of the small intestine, and it interferes with absorption of nutrients. So this slide basically shows that celiac disease, like other complex disorders, is multifactorial. There's several factors in play. One, here there's a clear genetic component. There have been genes that are identified that definitely give you risk, but that's not the whole story. It only gives you about 30% of the risk. There's different aspects of the immune response. Innate immunity means, basically hardwired immunity that's evolutionary, whereas adaptive immunity is more specific, where antibodies are made, and it's the way that we often fight infections. But here we have an interplay between genetics, immunity, and environment. And in this case, gluten exposure modulates all of this. So what is gluten? Gluten is a protein, it's a storage protein in wheat, barley, and rye. And it has amino acids that are called proline and glutamine, and it has a lot of them, so this makes it difficult to be broken down in the small intestine. And it's, in a very complex way, it is known to activate the immune response. So in a sense, it's almost, I call it like friendly fire. So the immune system kind of sees gluten as a potential pathogen and activates the immune response. And you can imagine that if you just ate all this gluten and it's lining your small intestine and your immune system thinks that it needs to protect you, it's going to activate the immune response there. And it's the immune response to gluten that then causes the damage to the lining of the small intestine. And like I said, because of the high proline content, it doesn't get broken down by the enzymes in the intestine. So I'm going to hand it over to Nasim.
I'm just going to add one other aspect to what is gluten. There is a common misconception that gluten is wheat only. And just to clarify, gluten, no, can't hear me? Is that better? Okay, there's a common misconception that gluten is wheat. And I want to clarify that gluten includes wheat, barley, as well as rye. So all three of those components. So, another common misconception, it's okay to try the gluten-free diet without doing any diagnostic testing. Fact, if you try the gluten-free diet without doing any testing, when you show up to see your physician, it's going to be very hard for us to tell you with certainty what is this diagnosis. Because your laboratory testing, your blood testing, everything else starts to improve, and then we don't have a way to confirm what it is that's causing your symptoms. And we'll talk in a little bit about some of the other things that look like celiac disease, but aren't exactly the same diagnosis. So please, if you are worried that you have celiac disease, see your physician first and get tested while you're still on gluten before starting the diet. What are the clinical manifestations of celiac disease? Well, many of you have maybe seen what's called the celiac iceberg. This is a visual analogy that talks about celiac disease. And what we used to think is that celiac disease was belly pain and diarrhea. That was because of what Dr. Fernandez-Becker just described, basically an autoimmune reaction to wheat. What we now understand is that there's a ton of ways that celiac disease can present beyond the gastrointestinal tract. Common misconception: celiac disease always manifests with gastrointestinal symptoms. So you can have celiac disease and have symptoms that are different than your gastrointestinal tract. What are the clinical manifestations of celiac disease? So this is a beautiful pie graph, and this represents many of the signs and symptoms of celiac disease. What you can see that's the largest in pink is diarrhea. And then blue, which says screening, and we'll talk about that a little bit more, but there's some people that have celiac disease and don't even know about it. And we find them because we screen or look for it. And then anemia, bone problems, weight loss, and abdominal pain, just to name a few. So before we talk more about celiac disease in particular, I think one question is, how can we use symptoms to distinguish celiac disease from other wheat-related disorders?
Okay, great. So one thing that I'd like to add in terms of the clinical presentation of celiac disease, if we go back to that pie chart, you notice that a lot of these symptoms are nonspecific. So they could, like a lot of these things, could also be seen in other GI disorders. So it's really common for people to have the diagnosis of irritable bowel syndrome for many years before we actually clinched the diagnosis of celiac disease. How can we distinguish between, so there's celiac disease where we understand what the immune reaction is. However, there's also what you've heard called non-celiac gluten sensitivity. And there's also wheat allergy. So these are not the same things. And with celiac disease, like I said, it starts as an inflammatory response. It results in autoimmunity. But wheat allergy is more as your classical allergy, and usually allergy is what's called IgE mediated. And this can result in swelling of the mucous membranes, sneezing, difficulty swallowing, and pain. And some people are allergic to wheat in that way. And then we have non-celiac gluten sensitivity, which is a little bit more difficult to define. And we don't quite understand fully what it is at this point. So the problem here is that symptoms really don't distinguish between the three possibilities. All patients could have very similar symptoms such as abdominal pain, diarrhea, in some cases constipation. All three entities could have some degree of neurological side effects. And, however, in the bottom and the other, you could see that there are some things that are specific to one more than the other. For instance, in celiac disease, it's associated with a rash that's called dermatitis herpetiformis. And wheat allergy tends to have more nausea. Non-celiac gluten sensitivity is a little bit more amorphous, but rashes have been reported, nausea and weight loss as well. So when it comes to basically this myth is, again, another common misconception that wheat allergy, non-celiac gluten sensitivity, and celiac disease are the same. They're not. They're very different. And going on a gluten-free diet will probably make all three conditions better. So that's why we would want to do the evaluation before you go on a gluten-free diet. And in terms of the mechanisms, so celiac disease, I kind of already tell you what the mechanism is. It's immunity. Wheat allergy as well. We know that it's a classical allergy, it's IgE mediated. But in the middle, non-celiac gluten sensitivity, we're not quite sure what's driving it. Recent studies seem to indicate that some part of the immune response is involved, but unlike celiac disease, it's not both arms of the immune response. And so far, we have a very unclear understanding precisely of why patients get symptoms. We have some ideas. It might be some other parts of wheat. Wheat also has complex carbohydrates. It might be low-grade immune response that we can't detect or we haven't learned to detect yet. So the bottom line is that right now it's a work in progress. There's clearly a population of patients that don't have celiac disease that are clearly sensitive to wheat. It's probably less than the number of people that don't have celiac disease and are on a gluten-free diet right now. But right now, there's no conclusive evidence that gluten is the problem. It might be another part of wheat. Also, like I said, in celiac disease, we both have the innate immune response and the adaptive immune response involved. So in this situation, it might be activation of the innate immune response without the antibodies that we get from the adaptive immune response. It could be an unknown cell-mediated reaction to another part of wheat. And finally, have you guys heard about FODMAPs? Great. So FODMAPs are basically an anagram for fermentable oligodisaccharides, monosaccharides, and polyols. Translation, complex carbohydrates that we humans just don't digest very well. So they've done studies that shown that a lot of people who feel better from the gluten-free diet is because we remove the biggest FODMAP in our diet, which happens to be wheat. And in terms of prevalence, Dr. Khavari already told us how prevalent celiac disease is. When it comes to non-celiac gluten sensitivity, we simply don't know because we lack biomarkers. And some studies suggest it's as low as 0.5% prevalent. Other studies suggest that it's much more, 6%. And we probably won't know until we develop a better understanding and have precise biomarkers to evaluate. Okay.
So going back to our patient, as you recall, she's a 41-year-old female who was having symptoms. She was still on gluten when she went to her doctor, who then did some blood testing to see whether or not she might have celiac disease. Her blood test was positive for an antibody called tissue transglutaminase, and it was very positive, so greater than 100, the normal limit being less than 8 mg per deciliter. So how do we confirm that this is celiac disease? Is a blood test enough? Well, there's a combination of things that we use to diagnose celiac disease, but right now in the United States, the guidelines are that we can do blood testing to see how suspicious we are for celiac disease, and then use endoscopy to confirm the diagnosis. It's probably difficult to see this table way in the back, but there are multiple different antibodies that we can look at to look for celiac disease, and we'll be happy to answer any specific questions at the end if anyone wants to know more about them. I think that there's 2 take-home points I want you to take from this slide. One, that there's one enzyme in particular that's the best one. It's called TTG-IgA. And then secondly, there's another antibody that we used to check for, and now we recognize that it has a higher false positive rate. That's called an anti-Gluten antibody. So sometimes somebody will see that one, it'll show up as positive, and it won't be as good for us to really tell. So just keep in mind that not every positive antibody for celiac is celiac disease. The other test that's on this list is a genetic test for celiac disease, and we'll also talk about this in a little bit more detail. It's called an HLA-DQ2-DQ8 test. And the really important point about this test is that 30 or 40% of the general population has the gene for celiac disease, but only about 1 to 2% of the population actually has celiac disease. So if you have the gene, it doesn't necessarily automatically give you the diagnosis for celiac. So it's just another thing to keep in mind. So on to making the actual diagnosis of celiac disease by the gold standard, which is called endoscopy with biopsy, which is something that we do both in pediatric as well as adult patients. Yeah. So what we do with endoscopy is we take first we make sure that our patients are asleep, so they're not feeling anything. And then while they're asleep, sometimes under what's called conscious sedation and other times under general anesthesia, especially in our pediatric patients, we put a camera that's about this width into their mouths, as you can see, and then we take a look inside of their GI tract, including what's called the duodenum, or part of the small intestine. In addition to looking, we take little pieces of tissue that are called biopsies that we then look at underneath the microscope. And a normal individual that does not have celiac disease has, let me see if I can find, has really beautiful little projections that are called villi, and those are there to help us digest food. A person that has celiac disease doesn't have those villi present, or if they do, they're blunted, they're not manifest as clearly. So the top picture you can see villi, they're kind of the little projections, and then on these bottom pictures they're less present. The reality is you really need a microscope to look at it, so it's not something you can easily see on this picture. But we look under the microscope and look for those findings that are consistent with celiac disease.
Can I go back?
Yeah, sure, please.
Sorry, I hope you guys don't mind us switching back and forth. Yes. So the small intestine is my favorite part of the human body, and I can't say enough about it. So one of the things that I could tell you is, like, on the top panel, there's these really beautiful, frilly, finger-like projections that we call villi. It almost looks like a sea anemone when there's air in there. And basically what happens with celiac disease is that these get destroyed. So what you see in the bottom is like gaps. And it no longer looks velvety, it looks more shiny and smooth. So the bottom is what we call an enteropathy, or something that we see in celiac disease. And as Dr. Khavari said, under the microscope, this is a busy slide for you guys, but the things that we look for are inflammation, how tall the villi are, and the shape also, because it tells us how severe the lesion is. And that's important to know because we want you to recover. And again, we can't say this enough. All of those changes that we told you about, the villus blunting, the inflammation, they kind of go away if you go on a gluten-free diet. So if you come to us already on a gluten-free diet for many months, it may make it really difficult for us to make the diagnosis because it may look normal, but it may look normal because you're already undergoing the therapy. And I think it is important to clinch the diagnosis, because celiac disease is an autoimmune disorder, and it affects, it's also associated with other immune disorders of the body, and it gives us an idea of how to monitor you. There's also most people do really well after they go on a gluten-free diet, but that's not entirely the case, and a few individuals can have some lingering symptoms. So it gives us an idea, if down the line things aren't the way we want them to be, to at least know what it was like at the beginning and have another point of comparison. So I'm going to hand this back to my colleague here.
So what about the rest of the family? So let's say that one person in your family was diagnosed with celiac disease. Does anyone else need to be tested? What do you think about your brother or your sister or your children? So I wouldn't ask this question if the answer wasn't yes. We know that when somebody is diagnosed with celiac disease, there's up to a 10% risk that a primary family member also has celiac disease. So at the time of diagnosis, we ask that all primary family members be tested. Testing in children, it's recommended that it starts at the age of 3 if you already knew that you had celiac disease, or at the time of diagnosis, or of course if they have symptoms. This goes back to what we briefly mentioned before. What do we know about the genetic predisposition of celiac disease? Well, when we look at first-degree relatives, 10 to 15% of them have celiac disease. And if we look at twins, identical twins have about 80% chance of both of them having celiac disease. And then dizygotic or unidentical twins have about an 11% chance. In order to have celiac disease, about 99% of the time, you need to have what's called the DQ2, DQ8 gene present. And what these DQ2, DQ8 genes do is they basically bind for a marker on what's called an antigen-presenting cell that basically attracts certain immune-type cells to a gluten peptide that's not completely digested. So if you are wondering if you have celiac disease but aren't sure, sometimes, but you've already been on a gluten-free diet, sometimes what we'll do is a genetic test to rule out rather than to rule in celiac disease. Does that make sense? But it's not good enough to diagnose celiac disease by itself. We also know that there's probably other genes that are responsible for celiac disease, and that could be a whole topic on its own. However, we do know that there's a lot of shared genes between other autoimmune illnesses as well as celiac disease. So if you're diagnosed with celiac disease, you'll see that we'll oftentimes screen for other autoimmune illnesses that can be related. So how do we evaluate a at-risk child for celiac disease? So somebody who may either have one of those other autoimmune diseases that puts them at risk for celiac disease, or if they have a parent or a primary family member. Well, we usually will screen them with blood tests at the age of 3 or when we find out. And then if that blood testing is abnormal, then we'll move forward with the endoscopy that was just described. Who do we screen for celiac disease in general? Well, anybody who is not gaining weight or not growing the way they should be, anyone who has those GI symptoms or clinical manifestations that we talked about, people that have joint problems and joint pains can sometimes have celiac. If liver numbers are elevated and we don't have another good reason for that, iron deficiency anemia and osteopenia, which is bone changes that we talked about. There's some skin rashes that will sometimes come with celiac disease. And then, especially in the pediatric population, we'll screen for some of those autoimmune illnesses like type 1 diabetes or thyroid or Down syndrome or Turner syndrome, some of which you maybe have heard of. And I think that I have beaten this point already. Celiac genes are not enough to make a diagnosis. So on to management.
Okay, management of celiac disease is lifelong gluten exclusion. One of the things that I should have said before, is that in a nutshell, what celiac disease is like our body misreading cues. So normally, when we are born, we're being bombarded with all sorts of new things, both good and bad. And you want an immune system that could distinguish friend from foe. For instance, if you get an infection, you want your immune system to be ready to protect you. But however, if you eat something like blueberries that has nutrients, you don't want your immune system
to be active. It turns out that your GI tract houses most of your immune system. And it makes sense because you're likely to encounter bad things. You're likely to ingest things. There's good bacteria, bad bacteria. So there is a process that we call tolerance, where the immune system learns not to get excited if you eat something, say blueberries, milk, that you need for your survival. And in essence, celiac disease is a breakdown of this process where your body is all of a sudden reacting to what should be an otherwise innocuous protein. And it becomes a vicious cycle. So if you have celiac disease, every time that you ingest gluten, it activates the immune response. So really the only treatment is to omit gluten from there. And it is a lifelong treatment. You know, right now it's a very exciting time in the field of celiac disease because we're understanding the pathophysiology enough that we're going to have drugs that will help us with this, but it will be as an adjunct to the gluten-free diet. Yeah, this is self-explanatory. So what is the gluten-free diet? We're just going to go through a few basics. And basically here these are pretty common real sources of gluten that are pretty obvious. However, there are also hidden sources that we need to be aware of. And when it comes to beer, a lot of people don't realize that there's gluten in beer. And one of my patients claims that Corona Light is almost gluten-free, but I tell him we have to avoid it. Okay, so we've talked about this. Wheat-free is not gluten-free. I think we've driven that home. Gluten is also in barley and rye. So these are some common hidden sources. Soy sauce, malt made from barley, some vinegars, usually malt vinegar. But a lot of people don't know that there could be gluten in medications. And that one's a tricky one because sometimes, and you would find it in the fillers. And what could happen is that it could change from one lot to the next. So sometimes if we're at a loss of why a patient's not getting better and where are they getting gluten, we may actually have to go as far as calling the manufacturer to make sure we know exactly what's in that. Play-doh, processed dough. And one thing that I'd like to make is like as physicians, when we see the patients, we're dealing a lot with the medical stuff. There's actually dietitians that specialize in the gluten-free diet who can devote a lot more time to making sure that they go over the diet with a fine-tooth comb. And that is part of the treatment. And we work, as physicians, we work very closely with dietitians. So patients often ask, what can they eat? And these are some gluten-free grains. Oats is something that comes up frequently, and technically most patients with celiac disease can tolerate oats. And the problem in the United States tends to be more cross-contamination because the oats are processed in the same machine that wheat is processed. However, so in general, gluten-free oats and oats from the UK, Canada tend to be okay in a celiac. But there is a small percentage of celiacs who do have a reaction to oats. And depending on how the patient is doing, we may or may not recommend to omit oats. There will be an enzyme that digests gluten. However, this is not a free pass to eat gluten and take the enzyme. It would be something that probably will help us with those times when we go out to dinner and get slight cross-contamination. Okay, and
Go ahead.
so back to my beautiful small intestine. What we want to see is that we go from the lining of the small intestine looking shiny, no villi, scalloped, to looking healthy like you have on the left-hand corner. And this happens for most patients, which is the good news. But it takes a long time, and it takes a lot of work because you have to avoid gluten. But the studies in the United States show that it may take up to 3 years. And there's no precise guidelines as to when we repeat an endoscopy to see if things are getting better. Obviously, if there's symptoms, we may do that as part of the evaluation. But if somebody's well, do we really need to repeat an endoscopy? But the consensus is that it would be reasonable to repeat an endoscopy after a couple of years. And this might be different in pediatrics.
Yeah. In pediatrics, the general thought and consensus is if you put someone on a gluten-free diet and their symptoms get better, then there's no need to recheck an endoscopy. So, do you want me to just one minute?
So, like we said before, most of the time things go well. But every so often there's symptoms. And a common misconception is that when there are symptoms that the patient has a more aggressive form called refractory celiac disease, but that's really just one small fragment. Usually the culprit is that there's still gluten. But depending on the situation, as this pie chart shows basically all the things that can cause symptoms in a patient with celiac disease. IBS could occur in a patient with celiac disease. We could also have patients who have fructose and lactose intolerance, as well as bacterial overgrowth. So there are situations where we treat the patient for bacterial overgrowth and the symptoms improve. However, if things aren't getting better and we exclude all these things, then we have to consider the more aggressive forms of celiac disease.
So what to expect after diagnosis? Usually if you're diagnosed with celiac disease, your physician will see you at the time of diagnosis along with a nutritionist to help think about practical aspects of implementation of the gluten-free diet. And then once people are doing pretty well, we'll usually see them on a yearly basis, and then we'll check labs relevant to whatever nutritional deficiencies they may have had from malabsorption in the past, and generally we'll screen for some of those other autoimmune illnesses every few years or so. Some pediatricians or family practitioner doctors are very comfortable doing that diagnosis, and then if someone is doing great, they don't have to come back and see us as gastroenterologists, and some people just prefer to come back to the GI doctor. So we really accommodate based on the patient and the pediatrician or family doctor. So in conclusion, we recognize that there's many forms of gluten and wheat intolerance, and what we talked about today was celiac disease, which is one kind of that. It's best not to eliminate gluten until after you've had some kind of screening done with your primary physician so that we understand exactly what it is that's causing your symptoms. And the treatment of celiac disease is a lifelong gluten elimination. And we're really lucky now to be living in a day and age where we have so many gluten-free products available to us, and in an area where we have so many gluten-free products available to us. So we would be happy to take any questions at this time. Why don't I start? Why don't I start with in the gray shirt? Yeah.
I have a lot of trouble with prescription drugs and trying to go back to the manufacturer. I've worked with my pharmacist and physician, and they seem to be having difficulties with that, with the prescription drugs. How can I best research that? I know we have the web, but is there any? It's very hard to. Anything you can recommend? So
your point is well taken, and you're right. So the question was, What about medications that have gluten contamination? And what can you do about that? The best resource that we have right now is glutenfreedrugs.com, which I know is not excellent at all, but it's sort of the best we have. And usually what we'll do is have you call the company or the manufacturer. Yeah, so I wish I had a better answer for you.
I'm going to come back to you.
I guess mine's a two-part question. I have two boys, one's 2 and one's 4 months, and I sort of discovered this wheat thing because when my older son, anytime I would have it, he would throw up from the breast milk. And so my two questions are, one, is 4 months old too young to screen for because he throws up anytime I get wheat as well, even just by cross-contamination? And then the second question is, I have cut out wheat since this one was 8 months old to try to prevent that, and I've never been screened, so I don't want to reintroduce it to my diet, especially with this one while I'm breastfeeding. So what would your thoughts be on that as far as the 4 months and then reintroduction?
Good question. You want to come forward?
Should I take this one? It's a pediatric question. Those are really great questions. So I think the first thing is to differentiate celiac disease from other wheat allergies. So your infants aren't getting gluten, probably aren't getting much gluten right now. And in fact, when it comes to the diagnosis of celiac disease, it really requires gluten administration themselves that they have to digest to be able to make this protein that then leads to the autoimmune response that was described earlier. So I would say that I couldn't tell you with any certainty that your little ones have celiac disease because they're too young to be ingesting gluten right now, especially the 4-month-old probably. That's not to say that it might not be a wheat allergy, right, which is a different set of symptoms that we can talk about a little bit offline if you want afterwards. So I think that was your first question. The second question is, when do you get tested? I think in the ideal situation, if you're noticing that wheat is affecting your children, then it probably does make sense to wait until you're done breastfeeding and then reintroduce gluten into your own diet and then go from there. Now, the one caveat I want to just bring up, and this is actually sort of beyond the scope of celiac disease, is this whole idea of wheat allergy. And I think as you're probably familiar with, in the past, we used to say, oh gosh, if you're worried about an allergy, wait until children are greater than 1 year of age and then start to introduce it in case they might have a severe allergic reaction. Now with time as a medical community, we're wondering if this concept of desensitization or earlier introduction of certain allergens may actually be better for the children in the long term and decrease the risk of allergy in the long term. So this is all still honestly being investigated, and we don't fully understand the science behind all of it, but I think it's a worthwhile discussion to have with your physician about should I be considering introducing wheat to my children who might be at risk for allergy earlier, because this may prevent allergy in the long run. Does that make sense? I can do it over here.
Hi, I have a couple of questions. The first question is about, I have IgA antibodies. I was tested, but they weren't quite high enough to meet the criteria for celiac. And so I'm wondering how you would interpret that and what you feel about the current scale for IgA testing for a celiac diagnosis. The second question is, I'd like to hear more about the relationship to bone health. I don't know how much time you have to get into that, but if you could touch on that briefly, that would be helpful.
That's a great question. So the question is IgA antibodies. Okay, so we use IgA antibodies because IgA is the type of antibodies that are made in the GI tract. But about 1% of patients with celiac disease are actually deficient. So I don't know if you fall into that category, but if you do have a normal IgA level, then the antibodies to tissue transglutaminase, which we call TTG, and deaminated gliadin peptide combined are actually very good diagnostic tests. So They aren't perfect, but when they are positive, they're almost about 95% accurate. And when they are negative, they are truly negative about 97% of the time. So if, I don't know precisely because by IgA, it doesn't tell me what kind of antibodies were tested, but if tissue transglutaminase IgA and or deaminated gliadin peptide IgA were negative, that casts a doubt on the diagnosis of celiac disease. Now, if we are, you have to look at the clinical context. And one possibility here would be that the genetic test may help. Because it's not so good to rule in the disease, but it's good to rule out. So let's say the antibodies are negative and you are wondering if you're at risk for celiac disease, then if you don't carry the genes that go along with celiac disease, then we could probably say this is not celiac disease. It might be non-celiac gluten sensitivity or something else. Now, the relationship between bone health and celiac disease, very good question. And one of the things that I recommend is after the diagnosis, after being on a stable gluten-free diet, getting a baseline bone density scan. And the concern is malabsorption. Remember how I told you that the small intestine is the workhorse where all of those nutrients are absorbed? That includes fat-soluble vitamins like vitamin D. So early bone loss could be a sign of malabsorption. So, and there's probably low levels of malabsorption even on the gluten-free diet. So we recommend, I check vitamin D, and I also recommend that patients take vitamin D supplements and get enough light because it's a clear concern. And the reason I screen for osteoporosis and osteopenia in my patients is what I call secondary prevention. This is, if we catch it early, then we can intervene. So it's very, very important to check for bone.
Hi. For adults, as far as diagnosis, I think I was tested for celiac after excluding gluten, so it had come back negative. And I'm still trying to do more testing to figure out diagnosis, but my osteopath is not really concerned about it. He's been sending me to derm for rashes and things, but nobody seems to understand. And I've gone to allergists as well, but they're doing IgE testing, not IgA testing. So it's hard to find should I be asking for referral to gastroenterology to try to link together the skin with the intestinal? I've also had a colonoscopy with diverticulitis, and it looks like your diagnosis is only with upper GI, not lower GI. How much is lower GI associated with malabsorption? And
so celiac disease mainly affects the small intestine, and there's debate as to why that is, but that's probably the first to see gluten, and that houses a lot of our immune cells. And most nutrients are absorbed in the small intestine. The colon absorbs water, absorbs some other nutrients like short-chain fatty acids, but the bulk of absorption and digestion occurs in the upper GI tract. And yes, I think it would be a good idea to sit down with a gastroenterologist who has expertise in celiac disease and go over all of this and come up with a plan as to how to make the diagnosis, because I think it's important to clinch it.
I can't walk all the way. Mine is maybe a combination comment and question. I was diagnosed almost a couple of years ago, and I'd be more interested to know the types of things that may occur when you first go off gluten, because I had just crazy resetting of hormones. I broke my ankle a year ago. So maybe talking about some of the things that happen when you eliminate gluten and you're healing and, just those types of things. So.
You're probably going to get a detailed discussion from this with Dr. Green's talk. He's going to talk about what happens after the diagnosis. But in general, you know, when we make the diagnosis, we have to assess what's going on in terms of like how bad, do you have nutrient deficiencies, do you have decreased bone loss, and for the most part, symptoms get better. But that's not a catch-all. There are probably some symptoms that are related to deficiencies. You know, some people could have neuropathies. That could be because their vitamin B12 is low or folic acid is low. But then there's the other part that we understand less. There's probably other autoimmune reactions going on, and those things may or may not get better. A classic case is migraines. In some individuals, they get better, and others, it lingers. In general, for the most part, things get better, but it is at a different rate for different people.
I'm not sure which one of you had the list up about dental. I'm wondering in pediatrics, when children's teeth are starting to, you know, come out, my grandchildren's teeth are quite spotted, and I'm wondering if maybe there's some kind of correlation between gluten and something like that.
So the question was about dental enamel defects, and is this related to celiac disease? So we think it is, but there's a lot of other things that can cause dental enamel defects, like cavities, like acid reflux, like the genetics behind it, dental hygiene. So usually the dentist will make a comment if they're concerned or not concerned. I would say clearly if they've got some other symptoms as well as dental enamel defects, and you think they've got pretty good hygiene, that would be an indication to probably get screened. Our screening tests are not as good in children less than 3 years of age, so just keep that in mind, in the back of your mind as well, yeah. But it's something that really needs further investigation, but there seems to be some kind of relationship between the two, yeah.
I was just diagnosed with celiac disease at the age of 73. It was picked up on a 23andMe that I had the 2 variants. So I informed my doctor. They did the blood screen. The antibodies were elevated. They just did a biopsy of my small intestine. And doing my research, it seems like most people are, you know, by the age of 40, it's diagnosed. Have I had this all this time and it's just been discovered?
That's a great question, which brings up one of the biggest controversies in our field. So, you know, no one really knows why certain people get celiac disease. Again, we said about 40% of the population carry the genes that we think are needed to get celiac disease, but only about 4 to 5% of those people develop celiac disease. So clearly there's other factors. So what is the trigger? What causes a person who has the right genetics to then develop celiac disease? We don't really know. And there is some mounting evidence that it may be a misguided immune response to innocuous virus or something. And in the process of your body, the immune system trying to protect you, may cause a little injury to the lining that is enough to then start this gluten reaction. Now, as your question, yeah, celiac disease could happen at any time. There's definitely the phenomena that patients are misdiagnosed with something like irritable bowel syndrome for years, and then someone puts it together. But there's also people who we know develop celiac disease new at age 70, 80, because we've done an endoscopy before and it was normal and now it's not. So it could happen at any time. We just don't understand what the trigger is.
I was recently diagnosed, and I don't have any of the classic symptoms. The only thing that I have is unexplained infertility and recurrent miscarriage, possible dermatitis herpetiformis. So my question is, how long after the gluten-free diet is in effect can fertility be improved? And is the jury still out on the correlation between fertility and celiac?
Yeah, so there's mixed reports out there. There's some reports that indicate that there is a relationship, but there's also population studies. So some studies have shown that if you look for celiac disease in patients who attend a fertility clinic, the incidence is higher. However, there's also been population studies that indicate that if you screen the whole population, infertility isn't necessarily higher in patients with celiac disease. So I think we have to take everything with a grain of salt. There does seem to be an association, and there's some molecular studies that seem to indicate that maybe these antibodies that we see in celiac disease may have an effect on the placenta. And what I can say is that we're not really sure exactly how soon after the gluten-free diet this will get better. It's variable, and there's really not a great way to predict. Anything else you want to say about this? Okay. And I know you had a question.
So I have the same case as the lady who was 73 and just got diagnosed with celiac. I'm 72 and I just got diagnosed 6 months ago. And my question is, I did not have very strong symptoms. I did not have bad diarrhea, but I did have headaches, a lot of burping. Anyway, I also have an ulcer. So it was very difficult. But my question to you is the same as the other lady, is how long does it take for this gluten to really come out of your body completely? And are my intestines ever going to be really completely healed?
Great question. So, you know, what I would say is when you start a gluten-free diet, it is a learning curve, right? It's not like you could go and one day you're completely gluten-free, you're learning. And in general, it may take months, but usually healing starts within weeks. It's variable of how quickly the mucosa fully heals. It could take a very long time, and I think you need to give it time, but the symptoms tend to improve before the lining is completely healed. And sometimes in some individuals, there's always going to be a small, like what we call treated celiac disease, where it's much better, but there's still some findings that will still correlate. So, but this is why it's important to follow up with your doctor to make sure that things are on track.
I think maybe what we'll do is stop the questions for now, but if anybody would like to ask any other questions, you are welcome to our booth, and we're happy to go from there. And there is another presentation on celiac disease at noon. The class schedule is present over there. So.